Dạ. Dạ, cảm ơn anh chị ạ. Em là Dương Hồng Phước, thì là bác sĩ về chẩn đoán hình ảnh. Thì vai trò của Phước là cũng để hỗ trợ với lại các bác sĩ phẫu thuật và bác sĩ về can thiệp trong việc chẩn đoán và chữa trị cho các em bé có cái căn bệnh Phuoc Duong and MAPCAs. And today I'm talking about mainly the role of CT, because MRI is not actually playing such a big role in this case for imaging planning. MRI has a different role in terms of the diagnosis and assessment, mainly function and shunt quality. But for CT is the best modality to look at the anatomy in greater details for planning. So first, I just want to show you the analogy of the journey of a doctor who want to manage this case. So there are two types of control that you can have. Two types of planning. As is here, you can see here, this one type is the recreational aircraft with a propeller. This is something that someone who just started training to become a pilot, and then use this technology to fly solo and go off and do lots and lots of fun things. Whereas this technology on the right hand side here is, you can see that is a top-notch aircraft, the Concorde, that's been unfortunately decommissioned. But you can see that the two journeys serve a similar purpose. However, in terms of the procedural planning, in terms of the usability, in terms of the friendliness, they are very different. One's there's a lot of panels. The pictures look very similar, or the controlling looks very similar. Whereas the other one, the easier technology will allow you to plan your routes out. A lot of automation, lots of colorful guidance. And this is what you're going to see. So then I'm using this analogy just to illustrate with the use of CT. In fact, it can actually make the procedure a lot more user-friendly, and also for the rest of the team to really understand the anatomy and management of this. This is the reason why we're just targeting this, is because in the past, catheterization is a mainstay of the diagnosis and management of pulmonary atresia, VSD MAPCAs. This is right up to 10 years ago. In the West, we have to use catheterization, but increasingly as time goes by, I don't see as much usage of catheterization right up until the patient needing the intervention prior to the case planning. So the good reason that we don't advocate CT is that with the CT imaging, you can provide a roadmap with very, very clear delineation of the MAPCAs, and then just to assist with the surgery. And surgeons particularly love all these colorful images, and you can actually see the roadmap. You can interrogate them and turn them on and off, and then do some different types of measurements. CT is quite actually easy to do. It's non-invasive, and it's really quick, and it's most of the situation does not require general anesthesia at all. And this is useful for cases when these babies, infants and neonates, are really, really small. The birth weight is really low, and then putting them to sleep under general anesthesia condition is a challenge, particularly if you interrogate them for 1 hour, 2 hours with catheterization. Sometimes it can be challenging for the patient's physiology. And with CT, with a roadmap that you can provide for the intervention, the cost of the radiation, the cost of procedure time, and no anesthesia is a clear trade-off as to the advantage of providing very, very clear pictures as to what one can do. With CT images, you don't have to have like a great expertise into the images to interpret the MAPCAs. But like in the catheterization, So with it clear data set, you can actually segment it, and then even just rendering, and you can see the anatomy. In this case, the patient has been partially unifocalized through a central shunt. So you can see there's multiple points of stenosis, and you can see the apparization of the branch pulmonary arteries, and any residual MAPCAs that has not been unifocalized, like the one down in the middle here, which can be done in the later stage. And you can rotate this around, you can spin, you can crop in and out, and then see the anatomy in greater details. And there's been lots of evidence showing that there's a clear correlation between CT imaging and diagnostic categorization as roadmap for surgical planning. With the good 3D CT data sets, you can actually use it to plan the procedure in greater details. It's the same example that I showed earlier. You can look at the MAPCAs in greater details. You can see where the main arteries is. In this case, the aorta, innominate artery, and then you can see there's one MAPCA coming out from the subclavian artery, and then the other one was coming out from the base of the left subclavian artery, and then the additional MAPCAs, you can see that they're coming out from the descending aorta, supplying pressure greatly to the left pulmonary artery, and then also significant parts of the right pulmonary artery as well. And with this, you can factor in factors, things like airway, proximity to some of these MAPCAs, which can help unifocalize planning easier. The role of catheterization is now reserved mainly to delineate the source of the dual blood supply for the lung segments, particularly to highlight between native blood supply from the antegrade pulmonary artery versus the abnormal sources provided by the MAPCAs. With a good CT data set, actually, these days, that can provide you isn't such high fidelity. Particularly in this case, for example, you can see that once the MAPCAs can be seen into subsegmental level at the lungs supply, and from there onwards, you can plan the procedure as to which one to be unifocalized and which one to be coiled off appropriately as well. This patient has got multiple blood supply to the different lung segments, you can see. And you can actually color them like that. This makes it a lot easier for everyone to look at. Excellent. And then with such data sets, if you wanted to do some practicing, we don't routinely do 3D printing, but you can see that from the previous slide to this one, it's just a few steps in between, but mainly with the technical preparation. You can print all these structures out, and then let the team plan to measure the distance, to see whether these MAPCAs can be potentially immobilized and then unifocalized thereafter. Another nice thing about CT versus catheterization is that, as you can see, it's just a natural course. If the patient just taken to the cath lab without further imaging, you can delineate the MAPCAs very, very nicely. But what is missing out from this is purely two-dimensional images flatten out into a plane, whereas with the CT you can see actually that the relationship of the two MAPCAs very nicely. As we know that yeah, they're all coming out from the right side of the aortic arch, but what is missing from this picture here is that so the temperature probe to go into the stomach here, that you can actually nasogastric tube in this case, to go into the stomach here. This is highlighted in the structure here. It goes in between the MAPCAs, and then normally when we just look at this, it's quite hard to appreciate that potentially could be something in between, and that's the point of this. As you can actually see additional adjacent structures like airway, esophagus, into and factor this into procedural planning. I just want to show just one other example, just to highlight the value of CT. Is that this is a patient that I had a few months ago. The baby, less than 2 kilograms, was born with no antenatal diagnosis, so just TED-PA MAPCAs as intracardiac anatomy is. And then when we did the CT before we planned the procedure, This shows that, like there's no native branch from main pulmonary artery stump. The whole branches are supplied by all these MAPCAs here, and predominantly one from the left hand of the patient here retroradially supply the left pulmonary artery towards the right pulmonary artery, and so on. And there's additional MAPCAs here. We said this potentially we can bridge these patients towards becoming bigger size, and then before we can plan to do some further reconstruction. However, with on the echo, we also found that there's additional diagnosis of TPVD, and with the value of CT, we can actually see that the case also has so this is the anatomy of the infracardiac TPPD, all these pulmonary veins joined together and coming to this confluence. But then going back to the point where I highlighted previously, as you can see that the relationship between the pulmonary vein confluence just to where the MAPCAs are really close to one another. And then we still discussed in our case conference, and we then said that potentially this is very challenging to manage, because when we fix the pulmonary vein confluence, potentially that could make the MAPCAs very hard to be immobilized subsequently. And this baby's man, due to other additional risk factors in the family, decided not to go for surgery. It's just simply because the additional value to this you can plan all of this without anything so invasively. Yeah, and then come up with a management that's potentially suitable for the team and then for the family of these babies as well. Yeah, so just the quick summary, as the previous speakers highlighted. So planning of the management of this condition is essential, and my message to use technology to help you assist as much as possible the procedure time, so that the journey can be pleasurable and you can enjoy the view. You can have pre-planning before you walk into the case, and then that will translate into good outcomes. And I show a lot of beautiful pictures earlier on, but then a lot of those are actually conducted by free softwares when you reconstruct it and then process them. So with good training, we can actually provide some good service towards the management of these infants, and the team can hopefully appreciate the value of imaging towards this as well. Yeah. So that's the end of my presentation. So thank you. Yeah, can I get my monitor? Yeah.